All right. Well, welcome everyone. We're going to be having a synchronous webinar here tonight. This is our Tuesday night national webinar series, and it's Phone a Friend, the greatest cases that I never saw. All right. Dr. Sowka is an attending optometric physician at the Center for Sight in Sarasota and Venice, Florida, which is a large medical surgical practice where he focuses on glaucoma and neuroophthalmic disease. He is the residency educator at the Center for Sight. He is also the director of optometric business development for USI. Joe, you're just took over the whole screen here for some reason. All right, here we go. He was formerly professor of optometry at Nova Southeastern University College of Optometry for 28 years, where he served as numerous academic and administrative roles. Dr. Sowka is a founding member of both Optometric Glaucoma Society and Optometric Retina Society. He is also a founder and former chair of Neuroophthalmic Disorders in Optometry Special Interest Group for the American Academy of Optometry. Dr. Sowka is glaucoma diplomate for the American Academy of Optometry. In 2021 and 2022, he's ranked number 4 optometrist, U.S. Newsweek magazine, America's Best Eye Doctors. Joe, congratulations. He was number 1 this year. Joe, the podium is all yours. Welcome.
Well, thank you, Greg. I appreciate that, and congratulations to you as well. You're also the top doctors in America in the 2023 edition. You know, I'm first, you're first. It really doesn't matter as long as one of us is first, right?
That's right.
Well, tonight is Phone a Friend, the greatest cases that I never saw. You know, like Greg, I get a lot of people reaching out via telephone, email, text. Hey, can I pick your brain? Can I get some help here? And we're always available to help people. We are in this with you. You're not out there alone. And what I did is I called together a number of interesting cases that came to me distantly, people who really I never saw. But I think I was able to help the practitioner and able to help the patient. Now, these are my disclosures. I'm a consultant or the advisory board or Speakers Bureau for Bausch and Lomb, but all disclosures have been mitigated, and I am a co-owner with Greg of this company. But here's some more disclosure. I work in a large medical surgical practice. I'm not in an academic referral center. I book 25 to 30 patients a day as primary care, glaucoma, emergency cornea issues, neuroophthalmic issues. I function much the way everybody else does here today. I don't take or have 2 hours to do a neuro-op evaluation. Now, what I want to say, the images presenting here may be of low quality. The information may be scant, but it's what I had to work with. And it was, in every case, enough. Now, what I want to point out or share with you is my phone number, 954-298-0970. Greg, if you want to put that in the chat later, you can. This is my email, joseph@optometricedu.com. If you have an issue, a case, something you're worried about, you want some help, reach out. You know, Greg and I are accustomed to doing this. You throw up the bat signal, and we're going to come. So case number 1, and this came to me indirectly through Greg because it came to Greg first via text, I believe. And it was a 27-year-old woman presenting urgently with a painful vision loss in her right eye. No known medical history. She has obviously an edematous optic nerve with hemorrhaging. She had an afferent defect, a superior arcuate scotoma, pain when she moves her eyes, and 20/70 visual acuity. Now, reportedly, the left eye is normal. This is all that I had. This is all Greg had. This is all that I had. This was what was sent to us from a practitioner out there asking for help. And you throw up the bat signal, and we come running. So polling question number 1, what's the likely diagnosis? Is it demyelinating optic neuritis? Is it non-arteritic anterior ischemic optic neuropathy? Is it arteritic ischemic neuropathy? Is it compressive optic neuropathy? Is it infectious optic neuropathy, hereditary optic neuropathy, infiltrative neuropathy, perineuritis, papilledema, or, gee, I don't know. That's why I'm here for you to help us. So I'm going to go back to this and let you take a look. And this is going to take a little bit of time, I think, for people to think about this. 27-year-old woman, urgently painful vision loss, a swollen edematous right eye. Apparently left eye is normal. We see some juxtapapillary hemorrhages, pain when she moves her eye. And the reason there are so many choices is this is what we have to think about. This is what we have to work through. And I think the most important thing that we're going to do in the lecture tonight, I'm going to try to accomplish, is working through a thought process. What else could it be? And why isn't it what we might think that it is? What rules things out? What rules things in? And I'm giving you all the information that I have. Greg, I think people are slowing down because this is a tough one. So looks like number 1 is demyelinating optic neuritis. I have a non-arteritic ischemic neuropathy there. Papilledema, we have a few takers on some of the other ones. Papilledema's got a few, and a lot of people say, I don't know. That's why I'm here to learn. All right, so let's think about this. This is a patient that screams optic neuritis. She screams demyelinating disease, multiple sclerosis. However, we have 2 problems here. One problem is she's got a papillitis. Her optic nerve is swollen. 2/3 of patients with demyelinating optic neuropathy and optic neuritis have a normal looking nerve. It is retrobulbar. Also, she has hemorrhages. Very important clinical pearl to always remember. Optic neuritis is not hemorrhagic. If you think that you have optic neuritis and you're dealing with demyelinating disease, and the patient develops a hemorrhage, either at initial or subsequent presentation, you need to rethink your diagnosis. Non-arteritic anterior ischemic optic neuropathy, well, she had a superior arcuate defect, and 6-1, it's going to be an inferior arcuate defect, and she has pain. Non-arteritic ischemic neuropathy is a painless disease. Arteritic, well, she's 27 or 20-something years old. We're gonna kind of take that one off the table. Compressive optic neuropathy usually isn't apoplectic or acute. It usually is rather insidious and sneaks up on us. Infection is on the table. We have to consider in a patient like this, there is some sort of infection leading to a secondary inflammation and pain. So that is on the table. Hereditary optic neuropathy is usually painless and typically male, so I'm going to kind of brush that maybe to the side. Infiltrative optic neuropathy also is on the table along with infectious. I think that is something we have to consider. Now, perineuritis is an interesting little infective condition. There's a number of things that will cause perineuritis. That is an inflammation of the optic nerve sheath that we can see on MRI. However, that presents with a swollen optic nerve, much like we see here, but the patient is asymptomatic. The vision is actually usually very good because it's the nerve sheath that's inflamed or infected. It's not the nerve. It doesn't have a dysfunction. Papilledema tends to be bilateral, and this is supposedly a unilateral, though it could be asymmetric. We didn't see the other eye. So we have a number of things here, and the first that we really think about demyelinating optic neuritis has a few things that are mitigating against it. But when I look at this is a thought process that I go through when I'm dealing with an acute optic neuropathy like this.
So the
So
question
in this,
rolled in,
okay, good.
just saying, what does the other eye look like?
Don't know. We were told it's normal. And that's all the information that we got via text and conversations. So I'm only giving you what I had. Good question.
Yep.
So infection and infiltration need to really be strongly investigated in a case like this. One of the common causes of infectious neuropathy, neuroretinitis, is often associated with cat scratch disease. And it will often have a macular star of exudates after about 2 weeks. But this may be missing early in the disease. But these are patients who will have a serous macular detachment early in the case. Now, in a case like this, we need a contrast-enhanced MRI of the orbits and chiasm and brain, because we do want to rule out enhancement and demyelinization. We also want to rule out nerve sheath swelling and perineuritis. So a contrast-enhanced MRI of the orbits and chiasm with fat suppression, because fat glows white on an MRI, and everything that's going to happen to the optic nerve is going to be white, so we want to get rid of that. And though I'm not thinking that this is demyelinating, we still have to, are obligated to look for that. So we want to look at a contrast-enhanced brain MRI for white matter lesions. We also have to look at a number of infectious agents: Bartonella, syphilis, Lyme, tuberculosis, herpes, Epstein-Barr. And this is what I'm going to do in concert with a primary care physician or infectious disease specialist. So our recommendations to this practitioner were to get recommend or help the patient obtain the imaging as well as the serology. Now, here's some new considerations we have to think about. They're not really on the table here, but MOGAD, MOG antibody disease. This is a immune-related disorder, inflammation of the optic nerve and spinal cord and the brain. So this protein, this myelin oligodendrocyte glycoprotein, is on the surface of the myelin sheath, and these antibodies eat it away. So it is a demyelinating disease. When dealing with suspected optic neuritis, we also are going to recommend anti-MOG antibodies. And neuromyelitis optica spectrum disorder is another inflammatory disease affecting the optic nerves and spinal cord. It's usually a sudden vision loss, sometimes a paralysis, or both. Symptoms after attack can usually improve, but it has got a relatively aggressive course. When we consider this, we have to order aquaporin 4 antibodies as well. However, in this situation, I really didn't consider it because I really wasn't thinking that this was a demyelinating type of disease. And again, with the papillitis and the disc hemorrhages, these are also not considerations. So patient got worked up, or we were told the patient was worked up, showed optic nerve sheath enhancement consistent with infectious autoimmune or granulomatous disease, no evidence of demyelinization, essentially said there's something wrong with the optic nerve. And that's all that tells us. Serologic testing was negative, except for very high titers: Epstein-Barr antibody IgG, Epstein-Barr capsid antibody IgG, and this was an infectious condition. So the pathogenesis of infectious neuropathy can be directly involve the nerve by a pathogen, or it initiates an inflammatory, degenerative, or vascular response. Now, looking at infectious optic neuropathies, you have a number of common causes. Syphilis can give a retrobulbar, a bulbar, a neuroretinitis, or a perineuritis. Now, retrobulbar and bulbar forms have a severe vision reduction, but perineuritis is a swollen optic nerve with normal vision. But it will actually enhance very easily on an MRI. Lyme is very similar to syphilis. In fact, they're both spirochetal bacteria. One is Borrelia burgdorferi, the other is Treponema pallidum. If you're in a Lyme endemic area, this is a strong consideration. Other conditions, toxoplasmosis, HIV, cytomegalovirus, very destructive division. Neuroretinitis, that's usually benign lymphoreticulosis or a cat scratch disease. Now,
Hey Joe,
neuroretinitis,
while you're in infection,
yeah.
someone raised the question, how about COVID?
How about COVID? I don't think I have an opinion on that at this time. We're still relatively early in our understanding of COVID. We're beginning to recognize other things coming out. This was not during COVID, so that was not a consideration. I'm not aware of any good studies or reports that really discuss optic neuropathy in COVID. And we were looking at some things in terms of uveitis, but I'm not really seeing much in terms of neuropathies in COVID. Good question. But neuroretinitis, we're used to seeing that macular star of exudates, but that comes about 2 weeks after the initial outbreak. The important consideration here is the relative afferent pupillary defect is relatively very mild compared to maybe severe vision loss, telling us it is more retinitis than it is neuro. And these are patients who are going to have not a mucky macula, they're going to have a serous macular detachment from the optic nerve all the way over to the macula. So the OCT is going to be a very, very helpful situation where we have a swollen nerve like we see right here. Here's a 62-year-old female who is being treated for strep throat for 1 day. She presents with count fingers vision in the right eye, a relatively mild afferent pupillary defect, a swollen optic nerve, and what we see here is that serous detachment. So the OCT is actually very, very helpful here and tells us we're dealing with an infection. So infectious optic neuropathies and the subset neuroretinitis, there are many potential etiologies. Toxoplasmosis, psoriasis, measles, syphilis, Lyme, simplex, zoster, Epstein-Barr. It just goes on and on. That's why it's good to work with other medical professionals in ordering these tests. Now, if it is a cat scratch with neuroretinitis, the prognosis is excellent. There's really no evidence that any treatment enhances or speeds anything up, but any sort of oral antimicrobial therapy, antibiotic that you like to use is as good as anything else if you want to give the patient something to do. If it is Bartonella, neuroretinitis, cat scratch, it's got a good prognosis. If it's something else, toxoplasmosis, syphilis, Lyme, well, that's going to be, needing treatment by a specialist, by an infectious disease specialist. So what is the pertinent information here? We got to look at the red herrings. Here's a young female with painful vision loss and an optic neuropathy. That really screams out optic neuritis and MS. You may want to think, well, let's just send the patient off to the ER and let them sort it all out. Now, if you're willing to help, yes, but that would have gone down the wrong diagnostic pathway. What were the important informations here? A swollen optic nerve, which is not common in optic neuritis from demyelinization, and disc hemorrhaging. It really just doesn't happen in demyelinating disease. So those are the pertinent information and the distractors that we have to be aware of. Greg, anything? Anything coming in?
We are good.
All right.
Last question
Well,
was about COVID, so we're good. And I've launched a handout, so the handout was
all
in the
right.
chat box. Yep,
All right. Sounds good. Can you still hear me, right, Greg?
I can.
Okay. 22-year-old female comes in for her first eye exam with blurred vision. This is one of my former students who is in our referral network, and he frequently texts me and asks my opinion. She's 20/40 and 20/70, no medical history, and he says she's relatively thin. I never saw the woman. I don't know anything. I don't know anything about it, but the bat signal goes up, and we come. We answer. We always answer the call. So he sends me these photos via text, and I'm looking at it.
Did you get it? But look, you put me up.
You
Nope,
got
I'll
that
get
one,
it.
Greg?
I'll find
Okay.
it. Yep.
So what we see here
How do I
are
get this off me?
bilaterally swollen optic nerves, macular star of exudates, hemorrhages. We have some cotton wool spotting going on. So polling question 2, what's the likely diagnosis and plan? She's got a bilateral CRVO, needs a coagulopathy workup. She's got idiopathic intracranial hypertension. We should prescribe Diamox and weight loss. She's got a brain tumor, need immediate MRI. She's got malignant hypertension. She needs blood pressure assessment and sent to an ER. It's infectious optic neuropathy because that's what the last case was. Or I don't know. That's why I'm here. So let's go back and take a look. I'll show you the information. 22-year-old female. Blurred vision. We see the fundus. And I know it was pretty campy, but I know there are probably a good number of people on the webinar tonight that have watched this TV show when it was on in the 60s and 70s, Batman. Na 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 Batman. Remember that, Greg?
I do.
Okay. Probably
The
a lot of people.
originals.
I'm going to say probably a couple people out there probably even had a cape in their closet. Greg, the interesting thing about these superheroes, for a certain population of people, and I'm going to say men, up to about age 30, superheroes actually not a fantasy, but actually like a career choice, I think.
We could put that as a polling question here. See how many people saw the original Batman and Robin.
Mm-hmm. All right, so I think we're pretty good. So I think we can probably shut it down.
Yep, I did. I'm sharing.
And most of the people are looking and saying this is malignant hypertension and they need blood pressure assessment and a referral to the ER. Well, I told our colleague, when you see bilateral disc edema and you see that degree of ischemia, I asked, what's the blood pressure? And the response was, well, I never checked. Let me go back and check. And I got the text a little while later. He said, the blood pressure is 180 over 144. And he said, that's being conservative. It's probably actually higher. So our likely diagnosis here was malignant hypertension, but it could be other things. This patient needs an ER consult, and they're probably going to still need neural imaging. But our likely diagnosis here is malignant hypertension. So we get the patient to the ER with information to tell them what's going on. Now, you may wonder what is causing malignant hypertension in a 22-year-old. The answer is that's above my pay grade. I just tell them what I'm looking at. It's up to them to find it, but I can probably safely say this is not primary essential hypertension, probably secondary to adrenal tumor. So what were the red herrings? The patient was young. She has a thin build. She has no known medical history, but the important finding here is the degree of retinal ischemia. If we take a look, there are a lot of cotton wool spots there. The veins are not dilated and tortuous, as we would see with venous outflow disease. We're looking at a patient who has got a very ischemic fundus, fairly dry eye action, not a lot of hemorrhaging, and this is consistent with the hypertensive retinopathy. So understand, the difference between the hypertensive emergencies and the hypertensive urgencies. The emergencies have a severe hypertension and end organ damage. That could be encephalopathy, intracerebral hemorrhage, myocardial infarction, and yes, retinopathy. The eye is an end organ. The hypertensive emergencies are going to require immediate blood pressure reduction to prevent organ damage. And this is best done through parental means after being admitted to the hospital. Hypertensive urgency, they have a grade 2 hypertension, but they don't really have any end organ damage. The eye is relatively uninvolved. And we usually find this under routine examination in patients who are not taking their medicine or not following properly with their primary care physician. And this needs to be sent back to the PCP. Anything going on? Which one are you, Batman or Robin? Well, because it's my lecture, I'm Batman. Greg's going to be Robin. If he's doing the lecture, we switch. Ethnicity of the patient, Rebecca, I don't know. I'm giving you only the information that we were given. Now, this actually was a patient that I quote unquote didn't see during COVID. This is COVID lockdown. So we are early in the pandemic. There was no vaccine, and we were actually pretty well in lockdown everywhere. He's a 39-year-old male who had been seen by one of my former residents. Previous history of migraine. He's a migrainer, but he gets a new and worsening headache with lethargy. He's very, very tired, very fatigued. He goes to the ER, where they admit him for evaluation. He undergoes a non-contrast enhanced CT of the head, an MRI of the head, non-contrast, which were reported as normal. So he went through evaluation, admitted for 3 days. His headache was attributed to migraine. He was given new migraine medicine, and then he was discharged. Now, 3 days later, he develops horizontal and vertical double vision. And that's when I get the call from my former resident. The bat signal goes up. Batman comes, and this is what we look, and this is what we see on him. You can see he's got a ptosis in the right eye, maybe a little bit exophoric here. When testing his motility, he has an adduction deficit, and he has an abduction deficit. So we have ptosis, we have elevation depression, we have abduction, and I'm listening to the conversation, and what I always do in a situation like that, and the patient was in the office. They open up the office just to see this patient. And I told my colleague, go film his motilities and text them to me. Let me see them. So he's describing it to me, but a picture is worth 1,000 words. So he's ptotic. He has got an adduction and an abduction deficit. So let's take a look at this. So he doesn't look up very well. He doesn't abduct very well. And I had it. I get this back, and I had to send my colleague back to do it again and say, I'm looking at it, and I mean, I can't tell if he's doing a physiological age or playing with a cat toy. This is like what my cat likes, like when I have the wand. So bring him back. All right, so an elevation deficit. Doesn't rise up all the way. It's got a ptosis. It's got an adduction deficit. An Okay, so his visual acuity and visual fields are normal. He's got a right pupil sparing partial third nerve palsy and a right sixth nerve palsy. He's also got worsening headache and lethargy. The question comes, where is the lesion? So it brings me to polling question number 3. What is the problem? He's got an intracranial aneurysm. He's got a migraine. He's got a brain tumor. Or I don't know. That's why I'm here. And Greg added one. I watched the original Batman and Robin on TV. Okay.
It's like everything's caught up.
Things are rolling in nicely.
Other than a question came in. Did you see that, Joe? And I was answering the polling question. It says MRA question mark. Was that the?
I'm not sure what that applied to. Was an MRA done on this patient? The answer is no. Patient had a MRI and a CT, both non-contrast enhanced, of the head.
We got a private message. It says Adam West was the real deal. Rest in peace.
I think Burt Ward is still with us, though. Is Adam West dead?
That's what I got as the
Okay.
direct message to me. So
All right. So
I will trust.
I think we.
When it was a new and in black and white baby. What was that? What does that mean?
So he watched it when it was new and when it came out in black and white, is what he's saying.
Oh, all right.
All right.
I was trying to think of something with the with your case. It's like, what?
So I hear aneurysm, I hear brain tumor. Not many people are bunny on migraine, and some people say, I'm here to learn, you tell me. And a lot of people watched Batman and Robin, the original. Some said no, some said I'm way too young. Okay, I can buy all that. All right. Well, I think it's pretty clear he's got multiple cranial neuropathies. He's got good vision. We need to contact the radiologist for another reading. Italian specifically looked in the cavernous sinus. And he looks, and the response is, nope, there's nothing in the cavernous sinus, but the pituitary gland looks a little bit chubby. And upon hearing that, that was the answer. Sent him back to the ER for repeat imaging of a contrast-enhanced MRI of the paracellular area and MRA at this time to rule out an intracavernous aneurysm and pituitary apoplexy. And his imaging came back. He had a pituitary macroadenoma that had hemorrhaged, and he had pituitary apoplexy. Now, interestingly, this went sideways, laterally, instead of vertically, like most of them will. And it spread into the right cavernous sinus and was beginning to spread into the left cavernous sinus. Now, there was no mass effect on the optic chiasm, so his visual field and his acuity were all normal. Now that we had this, the patient was immediately admitted for an endocrinological and a neurosurgical evaluation. Now, what is a pituitary apoplexy? This is a severe and a potentially fatal condition. And this happens about 10% of pituitary adenomas, and they're not always pre-diagnosed. Many patients are not aware they have a pituitary adenoma. There's an association of headache, sometimes vomiting. They can have visual impairment, abdominal paresis, altered mental state, lethargy, and it all comes from panhypopituitarism. They're not getting their hormones. They become hemodynamically very unstable. from adrenocorticotrophin hormone deficiency, and this can be fatal. This is a potentially fatal disease. And this occurs due to a very rapid expansion from a hemorrhage or an infarction of a pituitary adenoma, which may be pre-existing, they may know about it, or this may be the first sign they actually have a pituitary tumor. Now, looking at the anatomy, we got the pituitary gland, and above it is the optic chiasm. In most cases of apoplexy, it's almost like a hemorrhagic blood balloon. This gelatinous structure, which is the pituitary gland, kind of blows up. And for the most part, it will herniate superiorly, affecting the chiasm, resulting in a new acute onset bitemporal visual field defect. However, others will expand laterally. See, the chiasm is not involved here. There's no vision loss. The anterior portion of the optic nerves are not being compressed, but the cavernous sinus is being affected. 3, 4, 6, V1, V2. So a horizontal expansion is going to result in cranial neuropathies. Most common presenting symptom, headache, sudden onset, and it is usually severe. Apoplexy is overlooked as a possible cause of these debilitating headaches because in the ER, they're going to be looking for subarachnoid hemorrhage, venous sinus thrombosis, cervical artery dissection, and unless they're specifically looking for this type of condition, it can easily be missed. About half these patients will have some sort of visual abnormality. It could be blurred vision. It could be a bitemporal defect. Cranial nerve palsies can occur. 6 is very common. 3 is very common. 4 is not quite so common. Or if it occurs, it often gets buried under the other palsies. The visual field defects, if it expands vertically, is going to be a new onset bitemporal hemiopic defect. So most headache symptomatic patients will get a non-contrast enhanced CT of the head in the ER because they're looking for an acute intracranial hemorrhage. That's what they do. Now, acute hemorrhage may be seen on a CT, but if they're not hemorrhaging, these will not really show up very well without contrast. So it can easily be missed here. MRI with contrast is the most effective imaging if we suspect pituitary apoplexy, and the people who are doing the imaging have to be directed as to where to look. An MRI is going to be superior to a CT in this situation. Now, fortunately, while this is a potentially fatal disease, the outcome is usually pretty positive if it's caught. A lot of times patients will undergo conservative medical treatment where they have their hormones replace the pituitary hormones, stabilize the patient. Now, if they have vision loss or ophthalmoparesis or other neuro-ophthalmologic findings, they're most likely going to undergo a surgical decompression. They'll go either through the transsphenoidal area, the subfrontal approach, and that will usually be the treatment for patients who have cranial neuropathies or vision loss. Now, because this was COVID lockdown, nobody wanted to do anything on anybody. So the patient was diagnosed, was medically stabilized, released, and surgery was delayed until the lockdown was over. Ultimately, he underwent successful surgical decompression, and to my knowledge, is doing well today. So what is the pertinent information that we look at? And what are the red herrings? Well, he had no field loss and no vision loss. Now, pituitary issues, particularly in apoplexy, when the majority will expand superiorly, usually has a bitemporal defect, and it happens suddenly, but not always. This one went lateral. That's where the ophthalmoparesis comes in. Patient had a normal CT and normal MRI. I think it's very important to understand just because a patient sticks their head in a tube doesn't mean that the right thing is going to be found. You know, these are not Silicon Valley Rumpelstiltskins where you put in straw and get out gold. I think it's important for all of us to work together to get the best outcome for a patient. And he had been worked up in the hospital for 3 days. He'd been in for 3 days. One would think they're sure to find something. And he's already been diagnosed with a migraine. So he's probably just a migrainer. But what was pertinent? He had worsening headaches. All right, that was a different headache, rapidly expanding. He had lethargy, panhypopituitarism. He had multiple cranial neuropathies, 3 and 6. There are 2 places where they come together, in the posterior orbit or the cavernous sinus. Well, in the posterior orbit is cranial nerve 2, optic nerve. All right, if it's in the posterior orbit, they're going to have reduced acuity. He had normal acuity. All right, posterior orbit is out, must be cavernous sinus. We know what it is. We look at the motilities. They gets texted to us on our phone, and we come up with the proper diagnosis and potentially save this patient's life.
Joe,
Greg,
with
anything?
multiple cranial nerves,
Yeah.
was there any thought of myasthenia gravis at the start?
The answer is no. I'm gonna touch. I wasn't planning, but I'm gonna touch very briefly on myasthenia. No, because of the headache and the lethargy. Myasthenia is not gonna give you that debilitating headache. This is a person with migraines who knew he had a different headache. But interestingly, I'm going to tell you right now, I have seen or tested for more myasthenia gravis in the last 2 years than I have in my entire career. I'm saying I am probably testing for myasthenia gravis probably once a week at this point. I don't know why the prevalence, to be honest with you. Is there anything else out there, Greg?
Nope, just confirming June 9th on Adam West 2017.
They died?
Yep.
Okay. I am corrected. I stand corrected on that. Okay. All right. Here's a case from ODs on Facebook, School of Medicine. Let me tell you the story. So it's a Saturday. I'm on my patio drinking my coffee, scrolling through, reading the news on my phone. I touch it on Facebook. I'm scrolling through. I'm doom scrolling. And this visual field comes up. And I paused. I looked at it and said, okay, let me take a look at this. Let me go into this one. So this is good advertising because the person who posted this drew me right in. So I'm enjoying my coffee. I'm going to look at this case. Now, I've redacted most of the names, though I probably don't have to because it was on Facebook. But Rhonda presents this case, an 18-year-old type 1 diabetic with a gray area vision, right eye, happened 4 hours prior to her seeing her. Blood sugar in the office was 174. Consulted colleagues, decided to send the ER for a scan. Patient now in the ER, waiting 2 hours, not seen yet. Patient's mom has messaged me if they can leave the ER because it's nuts. People still waiting 6 hours. Can this wait until tomorrow? Now, there are about 84 comments in there when I read it. And I read through all of them. I'm not going to have all of them. But what do we see here? All right, there's an inferior arcuate defect on an 18-year-old diabetic patient. Apparently, the other eye is normal. I don't see a heck of a lot going on this OCT. And I look at the optic nerve, and that is a normal-looking optic nerve to me. All right, so I am now involved in this. I'm drawn in. So we take a look, and I don't really see much going on here in the OCT. Maybe there's a bit of an area here of hyper reflectivity, but it looks pretty symmetrical in both. The inter-eye symmetry looks pretty good. And remember, it was an inferior defect. So this part up here, all is looking really pretty good. I mean, am I missing anything here, Greg? Anything you want to add in, or is that okay?
Everything is good.
All right. All right, so let's look at some of the comments. Tiana said, I recently had one of these present with similar unilateral inferior loss, graying. Red cap desaturation was 10% of the affected eye. Optic nerves appeared normal. Mother diagnosed with MS around the same age, so she was concerned, but avoided coming in for fear of bad news. Sent to ER, MRI confirmed MS, white matter lesions, and optic nerve. I guess this was another patient who was put on IV steroids for 6 days. Oh, she was uninsured. So that was Tiana's patient. So now this patient has optic neuritis and MS. James says non-arteritic anterior ischemic optic neuropathy causes that exact field defect. Well, I agree with that. That's okay. I agree with that statement. Now, James says, Chad, sure, I've seen temporal arteritis in patients, plural, almost that young. Temporal arteritis in 18-year-olds. Okay, let's scroll on. Elizabeth says, nerves don't appear swollen. My first case of this was 22, 24-year-old, had to send for imaging, diagnosed MS. Does she have an APD? Did he check brightness acuity or red cap? Rhonda says, no, I didn't know an APD, did not do a red cap. She feels probably a little embarrassed by that. But when you're in the heat of things, sometimes you don't think about everything. Elizabeth says there's mild optic nerve edema on the OCT. Greg, do you agree with that? Is there optic nerve edema on the OCT?
Maybe inferior there, but not much.
But remember, the field loss or the issue is inferior, so that doesn't correlate.
Correct.
Rhonda, if you look at OCT, there's some mild optic nerve head edema, so likely diabetic papillitis with non-arteritic ischemic neuropathy. No need for ER. Just get blood sugar under control, order MRI, and if clear, monitor till it resolves. Okay, now the patient has diabetic papillitis and a non-arteritic ischemic neuropathy. Paul says, yes, it can wait. Mark asks, is she on birth control? It's a non-arteritic anterior ischemic optic neuropathy, and even is given the cause. Josh, I think diabetic papillitis is most likely caused based on the information. Check APD, confirm a red cap, want a fundus photo, would probably boot to retina, let them sort it out. Yeah, I can tell you, retinal specialists just love to sort these things out. Jay says, Josh, should be a variation non-arteritic ischemic neuropathy. Optic nerve will be swollen with fundus evaluation. I agree with that. Josh says, Ron, this might be a bit of a stretch, but is there a bit of a blurred margin at 12 o'clock on the optic nerve? So I look at the 12 o'clock on the optic nerve, and I agree there is absolutely nothing wrong with this optic nerve. Jill says, young female, most likely optic neuritis. Rule out in MS with MRI brain orbits with without contrast, flare sequences. Can be done outpatient, including IV steroids. Probably best to admit giving steroids. Hopefully neurologists will get involved. Now, Dorothy, group expert, says this is an AIOA. Brings me to polling question number 4. What is the likely diagnosis?
And Joe, you can look at Glenn's comment while I'm launching this.
I am type 1 for 47 years, none of those symptoms. Yep.
Joe, I explain, you know, the arteritic. You know, we have a patient here. It's fairly young, and you have taught me a lot of neuro over the years. So to me, it's quite obvious, but it might not be so obvious to our audience here tonight. And I know you kind of hit on it maybe 3 or 4 times there regarding that that arteritic, and maybe it makes us maybe chuckle a little bit. Can you just maybe why is there a chuckle effect?
Well, because it is not medically plausible in a patient under the age of 50. I mean, if you've got a patient, in their 40s, 30s, or 20s with biopsy-proven temporal arteritis, that needs to be published. It just medically doesn't happen. Now, we're getting kind of a good little split here, but if you say none of the above, what do you think it is? You got to put in the chat box. I want to hear. What do you think's going on here at the Facebook School of Medicine? We've had everything. Everybody, they said it's optic neuritis and MS, it's papillitis, it's temporal arteritis, it's non-arteritic ischemic neuropathy. And these are all things that the patient's being diagnosed with online. If you say it's none of the above, you got to give me something else. Visual field artifact repeat field. Okay, not unreasonable. But let's say Rich is still there. Everybody's thinking about it. So I'll let you take a look and monitor that, Greg.
Yep.
How do you know the other eye looks? Don't know. I'm only giving you what I got. Can you see the visual field again? Yes, you can. There it is. A nice inferior arcuate defect. I don't know what the other eye looks like. Presumptively normal. I said, this is phone a friend, the greatest cases I never saw. I'm only going by what was given to me.
Well, is that the other field over there, Joe, above your?
Yes. Essentially normal. So the other eye is essentially normal. All right. I can tell you right now, there's no good Samaritan right here. I looked at this, and some of these comments were getting pretty nasty, and I'm not getting involved. I'm considered a group expert on ODs and Facebook. Greg, I know you're a group expert. They expect us to get involved. I don't need to get into a fight with anybody on my weekend. I am walking away. I'm not making eye contact. I am leaving this one. I am not making a comment. Next morning, Sunday, I wake up, I'm drinking my coffee, and this is in my inbox, in my email, the same field. It's like Michael Myers in Halloween. This thing won't die. I can't keep it down. Yeah, it ends up back in my email, and this is how I went, because this was a person, Greg, in your network, and they finally reached out to you. And when you reached out to you, you reached out to me. So let's go through this. Greg, can you help me with this patient? She describes it. Entering acuity 2040, past exams, fundus and OCT, sent to the ER for a scan, secondary vision loss. I should have known better. I realize this now. The ER was a complete nightmare, but I was hoping Dr. Blankety Blank, the OMD on call, would see her, but he did not. The only doctor that saw her was a stroke doctor and seemed annoyed that she was even in the ER. They did a CT as well as some blood work. Everything came back normal. I'm also getting criticized for sending her to the ER, but I have done this in the past. Okay. So that's what was sent to you, Greg. And then you reached out to me. I was going to suggest that she send, will you help? Even though I don't want to get involved, I can't say no to my partner. If he asks me for help, I'm always going to help him. So now I'm getting involved in this. Now, I remember having a conversation, Greg, and telling you everything that is on Facebook is the anti-differential diagnosis. They are all wrong. It is retina. You can figure it out. You are great with the OCT and OCTA. You work those things like Elton John plays a piano. It's all going to be retina. So I think you saw the patient on Monday, and this is what you saw. What do you have here, Greg?
A nice cotton wool spot there, superiorly, a nice branch retinal artery occlusion.
Yep. And what did I tell you it was going to be, Greg?
Going to be retina.
It's going to be retina. And we do the OCTA, you have all this non-filling here, and this is a nice branch artery occlusion in this young diabetic. So what are the red herrings? The disc and fundus were normal. This is how an acute artery occlusion will present within the first several hours. She was only about 4 hours into it. Young, not the typical patient profile, but we know what it is now. Now we need to figure out what could be the cause. But what was challenging here, multiple opinions where they made the findings fit the diagnosis. We have to look at this and ask, what else can it be? Non-arteritic anterior ischemic optic neuropathy. The patient was too young, or it's not impossible, but very unlikely, and the disc was not swollen. It was just a normal optic nerve. Arteritic ischemic, are you high? I mean, come on, this is not in an 18-year-old. Diabetic papillitis. Okay, well, diabetic papillitis is a unilateral or bilateral swelling of the optic nerve in diabetics with no vision loss. They have no field loss, they have no acuity loss. It is largely asymptomatic. And optic neuritis, this was painless. Fully 93% of patients in the optic neuritis treatment trial had painful vision loss, pain on ocular motility. And you may say, well, 93%, had pain, but 7% didn't have pain. Well, those are patients who were misdiagnosed in the study and didn't really have optic neuritis. So you can't make the findings fit your conclusions. There are reasons why none of these were on the table. What was the pertinent information? Acute painless loss of vision just happened. Fundus and disc normal. That's when you have to consider an acute artery occlusion. This is the patient we saw in practice. The fundus doesn't look, it's a little wonky. It doesn't look all that bad. When you look on the OCT specifically, let's say central artery occlusion, you've got this shadowing effect here. And it's almost like the retina is split because the retina is edematous and it shadows. So this is what you're looking for in a presumptive acute of hours duration artery occlusion. So we have some new guidelines here. I'm gonna expand upon it as well. Any patient with arterial transient ischemic attack or acute retinal ischemia need to be worked up in a stroke unit. So I think we're all pretty much understanding that now. These are patients that have to have immediate brain imaging, brain MRI with diffusion weighted imaging, looking for these small cerebral infarcts that portend a higher risk of stroke. Two friends of ours, Doctors Nancy Newman and Valerie Buse, who are neuro-ophthalmologists out of Emory, have been leading this charge for several years and really have advanced our understanding of how to manage these patients. The imaging is abnormal in about a third of patients with retinal artery occlusions and about 20% of patients with transient ischemic attacks. So these are patients that really need to be handled urgently. So is this something that should or could wait if you know what it is? The answer is no. Diffusion weighted MRI is going to identify a subgroup of patients who are at very high risk of a major stroke. And this really needs to be done within about 24 to 40 hours in order to get the proper stroke prophylaxis. Now, when dealing with patients with acute retinal arterial ischemia, not venous ischemia, arterial ischemia, and that includes transient ischemic attack, transient monocular blindness. 10 to 15% of these patients are going to have a disabling stroke within about 3 months, and about half those patients will occur within about 48 hours. They need diffusion weighted MRI within the first 48 hours. They need CTA of the cervical and intracranial arteries. They need EKG and echocardiogram. They need CBC and platelets, coagulopathy assessment, lipid. They go to the stroke unit. They go to the ER. We don't want to try to do this workup ourselves. The patients have to be told, go to the ER, preferably a stroke-ready hospital. Tell them you had a retinal stroke. Don't go to the PCP, cardiologist, neurologist, neuro-ophthalmologist, and don't do the workup yourself. Greg, have I missed anything here that you would like to add?
You did not, but I will stress that, tell them you had a stroke to your eye, a retina stroke, a heart attack to your eye. Don't tell them it's a branch retinal artery occlusion. Don't tell them, it's, whatever the fancy eye terms are. It's a stroke to the eye. They understand what to do then. That's out there.
And in fact, the American Heart Association considers central retinal artery occlusion to be stroke. They call that stroke. Apparently, question number 5. Greg, a patient with a TIA or retinal artery occlusion has mild carotid stenosis, less than 50%. The issue is therefore not caused by carotid disease. Do you agree or do you disagree? I think most everybody has been involved in some sort of workup where a carotid study is done, might be ultrasound, Doppler imaging, and the stenosis is mild. Less than 50% stenosis. So therefore, whatever is happening in the vascular system, that it's not carotid disease. Do you agree with that? Or do you disagree with that? Anything good happening out there, Greg? Any direct messaging?
Nothing direct has come to me. We're all caught up.
All right, very good.
I will end the poll. I'll share the results.
Very nice. Almost 50-50. Some agree, some disagree. About a good split. All right, well, here's something that's new. And Greg, I don't know if you're aware of this. And I don't think that you and I have talked about this yet, but this is some new information. This is a prelude to what I think is going to be coming in the next several years. Finding these etiology, here's some new thoughts. There's something called sync-in. Sync-in, not NSYNC, but sync-in. When we consider these issues of artery obstruction, stroke, it's always based upon the degree of carotid stenosis. How closed off is that artery? Now, if there's a low degree of stenosis, usually less than 50% stenosis, it is automatically dismissed as a cause because it's not, quote unquote, bad disease. But now there's some advanced MRI techniques that are identifying high-risk features of plaque. Now we actually have a condition called symptomatic non-stenotic carotid disease, or sync-in or NSYNC, if you want to call it that, where the stenosis is less than 50%, but it is still the cause. And they've seen that on the ipsilateral side of an ischemic event, there are some high-risk features: intraplaque hemorrhage, fibrous cap ulceration, hematoma, thick, rich lipid core. And these are people who don't have bad carotid disease, quote unquote, but they have high-risk lesions. So what we have here, we have an atheroma forming, a plaque forming. And many of these patients that are stable have a very thick, what's called fibrous cap. They've got a smaller lipid core, and it's fairly stable. But this cap may actually be relatively thin and fragile, and the lipid may actually be pretty extensive. And this is a high-risk situation. So what happens is this thin fibrous cap will rupture. The lipid can leak out. We get this red thrombus, and we get a new onset of thrombosis with subsequent embolism. So the patient may actually not have much stenosis. It's actually under 50%, but the lesions, the plaques are fragile. That there's a very thin fibrous cap that leads to a rupture. There's a lot of lipid in there. We get the clot that forms, and it can embolize. So the symptomatic non-stenotic carotid disease, or sync-in or NSYNC, seems to cause stroke. Now, angiography really just looks at the degree of stenosis. But and ultrasound's the same way. It tells you how stenosed it is, but it doesn't identify any of these high-risk characteristics. You need a dedicated MRI sequence to look at this intraplaque hemorrhage, look at the degree of lipid in the core, and how thick is that fibrous cap. Because these are things that make the lesion unstable and at risk of thromboembolism. And it's not even really that stenosed or occluded. So this really requires a dedicated MRI protocol, which is not right now feasible in a lot of centers. CT angiography is a standard for acute ischemic stroke and is performed in almost all these patients. So what really needs to be done is to establish similar imaging markers that can be used with the CTA. Right now, there's no single reliable CTA imaging biomarker that can identify these fragile plaques. But I'm going to tell you, this is why we need to work with professionals. We ordered carotid Doppler, comes back 48%. We're not worried about it. Well, we don't know that it isn't the cause. So this is why we need to work with professionals. They're going to have more dedicated MRI protocols and CTA protocols in the near future, so that we may actually be looking at people who have not really significant carotid stenosis, but that is actually the cause of their stroke and their artery occlusion and their TIA. So this is all very new information. Probably more information is going to be coming in the next couple of years. Can you repeat what you said about the retinal findings show edema and ischemia after artery occlusion? Yes. The inner retina is going to be very edematous. In fact, I'll go back and show it to you. The inner retina is going to be very edematous, and you can't see anything. It's shadows there that looks like it's split apart. It's not split apart. It's a shadowing from the edema. When should most people have a carotid Doppler prophylactically? I don't know. I think I would leave that up to the cardiologist. What is here lipid profile?
What is her probably
maybe
lipid?
her lipid profile? Don't know.
Joe, go stay at that seat, or stay at that OCT. And probably the best thing to look at is in the foveal pit there. If you show the ellipsoid zone and the RPE, how it's lighting up, that's because the signal can get through there because there's no edema.
Excellent point. Excellent.
And then if you go to the sides of that, there's no really you can see the RPE, but it's not glowing there or hyperfluorescing or like the ellipsoid zone. And again, that's a good way to point it out because the signal's being blocked by the upper edema of the outer retina.
That's my Robin. Actually, that's an excellent point, Greg. So we're going to get more information, but we really need to work with professionals when trying to assess this. And there are some high-risk fragile plaques that may not be as significant as one thinks. All right. Anything else coming, Greg?
Let's see. Sorry, at what point could you identify these findings in an OCT after occlusion?
On the OCT, almost immediately.
Yeah. So what's going to happen there, Natalie, is that, when it first happens, right, you twist your ankle. You think you twisted it, but then 2 or 3 days later, oh yeah, you twisted it and swelling has occurred. So when these occur, there's no flow through that inner retina because that's where the capillaries are. And that's why you kind of get that kind of initial swelling, bogging down, blocking of that signal. So that's going to happen immediately. Then what happens is, 3 or 4 days later, you get that cotton wool spot that shows up of that retinal ischemia. Now the nerve fiber layer is starting to swell. So the finding that Joe's pointing out, kind of that signal blocking of the outer retina is going to happen immediately, and then you'll see the other retinal findings show up 3 or 4 days later.
Looks like there's something else coming in the chat. Okay, thank you. Very good. All right, help. I think I've got a third nerve palsy. 75-year-old Caucasian male, and I know this is my former resident, now current colleague, who I know is on the call tonight, on the webinar tonight. So if she wants to get involved and get in the chat room, go right ahead. I think I have a third. 75-year-old Caucasian male, long-standing complaints of double vision. Denied any acute episodes of double vision in the past, never diagnosed with any cranial neuropathy. He has a history of malignant non-metastatic intestinal cancer, diagnosed 7 years ago, had surgery, and was removed. Best corrected acuity, 2100 right eye, 20/20 left eye, and he has a macular hole, lamellar, and that vision is consistent. There's no afferent defect. I think one of the most pertinent things was, Greg, we were doing our Arizona meeting, and this patient saw my former resident in our Sarasota office, and thank goodness the patient didn't have an 8 a.m. appointment, because I would have been getting called at 5 o'clock in the morning. So I'm glad that didn't happen. So she's talking to me about it, and my response is, okay, you got double vision, you have ophthalmoparesis, go film it and send it to me, and then I can help you. Now, he has a right adduction deficit, limited supraduction, limited infraduction. Abduction is fine. He's got no ptosis. Pupil's normal and reactive, and there's no constriction of his pupil when he attempts to adduct. So he has no ptosis. He has an adduction deficit. Abduction is fine. Supraduction is relatively limited. And let's look at his motility. I'm going to show this to you twice, and we're going to dissect it. So adduction deficit, elevation deficit, a little bit of a depression deficit. Excellent. All right, let's look at them again. All right. So polling question number 6. Is this a third nerve palsy? Yes? No? Kinda, sorta, maybe-ish. Could be.
Comment, mild ptosis, left eye, question mark, and
Nope.
Decompensated for you, question mark.
Nope. I looked at the video about 5 times to make sure I was actually seeing what I was seeing, and the diagnosis was split second, but it was there, and I'll show you. We'll look at it in just a second. But no ptosis in the left eye, and no ptosis in the involved right eye either. Okay, looks like we're slowing down here. So is it a third? Some say yes, some say no, some say kinda, maybe, sorta, maybe-ish. Okay. Question 7. What is a problem? He's got a third nerve palsy from an aneurysm. He's got a third nerve palsy from a tumor. He's got myasthenia gravis, or he's got aberrant regeneration from a cavernous sinus mass. Let people think about that one.
Question came in, was right eye proptotic?
It was not. Good question. Was not. And there's a reason that you think maybe it is, but it isn't. When we might say it's pseudoproptotic because of a certain appearance. Excellent. Question's getting tougher. All right, I think we probably should consider calling it here. All right, some people think there's an aneurysm, some people think there's a tumor, possibly myasthenia, or very nice, interesting, aberrant regeneration. All right, let's go back. I'm going to show you. I'm going to stop you where it happens. Right there. Do you see all the scleral show there? And that's why you may think he's proptotic, because the lid is retracting. Let's do it one more time. Lid goes down and lid goes up. Lid synkinesis. I looked at that maybe 5 times, and every time I saw it, I said, yep, this is a person who's got a cavernous sinus mass. So this is one we cheat a little bit on. I actually did see the patient in follow-up after I got back from our meeting. Let's take a look at him again. All right, lid is almost closed. And look how it goes up. Abduction goes down. And lid goes up. Synkinesis. There. That's just one. Let's look one more time. Learn this, live this, love this. Abducting, lid goes down. Adducting, lid goes up. And that's it. He's got aberrant regeneration of the third nerve. Damage to the third nerve resprouts and miscommunication nerves to muscles. So what happens, the inferior rectus and medial rectus will communicate with the levator, and sometimes the medial rectus will communicate with the pupil. So what happens? The patient looks medially, they adduct, the lid elevates. Right? They look laterally, the lid goes down. They look down, inferior rectus communicates with the levator, the lid goes up, what is called a pseudo von Graffi's. And sometimes they look medially, the pupil will constrict. That did not happen in this patient, and the pseudo von Graffi's did not happen in this patient, but he had lid dyskinesis. Now, after an aneurysm, trauma, tumor, aberrant regeneration is expected. This is a person who had an intracranial aneurysm. He developed aberrant regeneration. Secondary to a known third nerve palsy. This is a person who's developed aberrant regeneration but has never had a third nerve palsy. This means he's got primary aberrant regeneration. This means there's something slow growing in the cavernous sinus. Either an aneurysm or a tumor, typically a meningioma, is going to cause subclinical compression and regeneration at the same time. So this is a long-term developing situation. Secondary aberrant regeneration is expected after aneurysm, after trauma, after tumor, after inflammation. It doesn't happen after ischemia. If you ever see aberrant regeneration after an ischemic third, there's another cause that must be found. And when there's been no antecedent third nerve palsy, I mean, there's something slowly growing, most likely a meningioma within the cavernous sinus, but the man does have a history of cancer. We have to consider this as a possibility. Now, an intracavernous aneurysm is not an emergency because it is fairly tightly packed in there, and it does kind of prevent the aneurysm from rupturing. Also, if it ruptures, the blood is still in the venous system. Now, a posterior communicating artery aneurysm in subarachnoid space, if that leaks and bleeds, that's going to probably cause death. Now, can a extracavernous aneurysm cause this to happening? It's very, very unlikely. Those have a tendency to grow, bleed, and rupture. So, what's our approach? We've got to look for orbital disease, cavernous sinus disease, and of course, we want to make sure there is no extracavernous aneurysm. We need an MRI with attention to the orbits, paracellular area, cavernous sinus, and an MRI of the circle of Willis. CT and subsequent MRI show soft tissue mass in the cavernous sinus. It's encompassing the internal carotid artery, most likely consistent with a meningioma or a lymphoma. Now, because he did have an oncologist and he did have a history of cancer, was able to contact his oncologist, who agreed to order a PET scan to make sure there's no lymphoma. I think presumptively that came back normal. Discussed it with the patient, no good options. Surgically, not really accessible. Radiotherapy, not very responsive, and you have the risk of radiation disease. The chemotherapy, it's not a malignant disease, a meningioma. So, observation is potential. We had a discussion, and he has agreed to be observed. So, what are we going to dissect the pertinent issues here? He had evidence of third nerve dysfunction, but no ptosis. It was chronic. And the most prominent feature of aberrant regeneration was not present, the pseudo-von Graefe side. When he looked down, the lid didn't come up. But what was the key feature? The lid synkinesis. It lowered with abduction, elevated with attempted adduction, lid synkinesis, aberrant regeneration of the third, localizes cavernous sinus. There's a slow-growing lesion. Greg, anything come through?
Nope, they're all caught up.
All right, good.
And I think I'm going to do the handout just so everyone knows one more time. I did it earlier. I'll do it again right now.
All right. Now, Greg, I remember this one. We were all sitting together in an airport somewhere. I think we were heading to Germany at that time for our Heidelberg meeting. And the bat signal went up, and it went to you, and you asked me about it. And I don't think we really talked a lot about this, Greg, but I can't tell you how much I really liked this case, because it's just so doggone logical. It's a 30-year-old male. This comes through text from a friend of Greg's, and Greg just asked me to opine as we were sitting next to each other in the terminal, waiting for an internally long delay. Complains white looks weird in his right eye for a day. 20/20 in each eye. Pupils normal, dilated exam normal. He felt worse the next day. Medical history unremarkable ? Don't really know his medical history. On penicillin for 10 days from a sinus infection. And here are the fields. And what do we see? We see bilaterally constricted visual fields in a symptomatic 30-year-old who's having an issue of 1 to 2 days duration. Have you ever had a bilaterally constricted field patient of unknown etiology? Let me know. Just put it in the chat. Have you ever seen this before? Have you ever come across this and wonder, what the heck is this? Lori asked, is he allergic to penicillin? Not a bad thought. Lori, I don't know. I'm giving you only the information that Greg and I got. So can you remember ever come across this? Hey, ever see something like this and not really sure what to do, what it is? Natalie says very mildly reminds me of clover, the clover effect. Yes, we're going to talk about that. Well, let's say that this is real. And let's say this is, what we're seeing here in this 30-year-old, maybe it's reproducible. And he is symptomatic of, it's just something wonky in his vision. Now, I don't know what the guy looks like. I know nothing about him, never saw him. This is the only information. Now, apparently he did go to an ER where they did a CT and a CTA with contrast, and it came out normal. And I know the person who reached out was somewhat chagrined that they have difficulty getting an MRI in the area. Well, I can tell you, in the right hand, CT and CTA, contrast, it's not like an easy bake oven. That's pretty good imaging. That can be pretty effective in finding things. So you shouldn't think that the CT is an easy bake oven and that you need to get an MRI that it will find whatever a CT won't, because that's just not really true. Nicholas, you say toxic. I like the way you're thinking, Nicholas. What's going to cause bilateral sudden field constriction in a 30-year-old with normal neuroimaging? Is it intracranial disease? Is it something he ingested? Does he have a bilateral optic neuropathy? Nicholas, I like where you're thinking, because I was thinking kind of the same way. I'm thinking that there's something ingested. Now, the challenge in a situation like this is getting the history, and I can't do it, man. I'm not seeing the patient, but getting that history out, that can be a challenge. Because some patients may not be aware of certain relationships. They may not be open with certain things. How long would it take? Laura, I'm not sure what the question, like how long would, okay, I missed something here. Richard says, someone who had a lot of PRP could have those fields. Richard, you're entirely right. That's why I like this case. It is so doggone logical. So, Richard, you are right about that. Natalie, you're right about the clover field. We're going to look at all of these things. And Lori, I think you're asking how long would toxins take? I hear a conversion disorder. Okay. A lot of things here. But let's talk about toxic optic neuropathy. One more thing in the chat. Retinitis pigmentosa early. Good thought, James. Like I said, I love this case because it is so doggone logical. But let's talk about toxic neuropathies. It is typically bilateral, usually symmetrical, involving the papillomacular bundle, vesico or secocentral scotoma, and usually reduced color vision. Now, keep in mind, I'm only giving you what came through via text. Nutritional deficits, vitamins like thiamine, riboflavin, niacin, folic acid. These can trigger enhanced toxic neuropathies if they have a nutritional deficit. Certain medications, high dosing, prolonged exposure, or overdosing can cause it. Maybe there's exposure to a toxic substance in the environment. So what are potential toxins out there? Alcohols, commercial alcohol, methanol, and ethylene glycol. Ethylene glycol, that is drawing a blank. Anti-refrigerant.
Antifreeze.
Antifreeze, very good. Obviously, where I live, I don't see a lot of antifreeze. But, ethylene glycol is one of the components, what I call the murder kit. Some people get poisoned by that. Antibiotics, chlorphenicol, sulfonamides, linezolid, antimalarials, hydroxychloroquine, the anti-tuberculosis drugs, isoniazid, ethambutol, big one I highlight there, streptomycin, antiarrhythmics, amiodarone, anti-cancer, vincristine, methotrexate, tamoxifen, anti-seizure, vigabatrin, very big one for constricted fields, vigabatrin. The phosphodiesterase inhibitors such as sildenafil, heavy metals, thallium, mercury, lead, carbon monoxide, tobacco. And keep in mind, if you look at some of these things, patients may not be aware they're being exposed to this. And I said, things like thallium and ethylene glycol come in what I call the murder kit. People get poisoned by other people.
Joe, go back to your ethambutals, and I think who was it that was asking about the timing here? I can tell you that I've seen these ones from ethambutol, from these amiodarones, probably seen 3 ethambutals, and I've actually warned the patient. And I have a great case of one where she's actually a glaucoma patient, understands visual fields, told her about it, and the key with these ones that are not like Joe's talking about, the poisons, like the alcohols and the glycols, those are going to kind of be like more sudden, like they took some poison and it kind of stroked out the nerve or created that toxic optic neuropathy. But so it's not ischemic, so it's not a stroke, but kind of that toxic optic neuropathy. But these ethambutals, these medicines, these chloroquines, these quinines, it's so slow that they come in almost looking like these visual fields that Joe's presenting here. But I've warned the patients, told them about it, and they come in almost in that 9th inning. And you're like, how the heck did you get here? Because they're so slow. And there's one case that I have where we're able to identify it, stop it, and it reverses almost all the way back to her glaucoma defect. It's really, luckily we caught it in time. So it all depends on what toxic optic neuropathy, but these ones from medications, even though you warn them and tell them, they're just so slow that they don't come in until like the 9th inning. If that helps.
Excellent points, Greg. Excellent points. Alcohols, commercial alcohol, methanol, ethylene glycol, chronic alcoholism is going to lead to folate B12 deficiencies that can accumulate formic acid, inhibits mitochondrial function. Methanol, white lightning can cause, retrolaminate optic nerve delamination. You can get brain edema. These are all things that can happen relatively quickly too. The antibiotics, Zyvox, prolonged Zyvox usage can disrupt the mitochondria and protein synthesis. The antimalarials, hydroxychloroquine can cause toxicity. Ethambutol is a big one, as Greg mentioned. This is disruption of oxidative phosphorylation. It's going to really cause in many cases, an irreversible damage. Antiarrhythmics, amiodarone can interact with the polar lipids, can lead to optic disc swelling, induce neuropathy. Toxic amiodarone in peripheral nerves has actually led to loss of axon and demyelination. The phosphodiesterase inhibitors, such as the erectile dysfunction drugs, sildenafil, Viagra, this really more causes not a direct toxicity, but it has been shown to be associated with a non-arteritic anterior ischemic optic neuropathy. But the risk is very small in a very small number of people. Heavy metals, lead, mercury, thallium, they can cause protein structural changes, disrupt biochemistry, oxidative stress, and a patient may not be aware they're being exposed to these. So history consideration, look for exposure in the workplace and the environment. And some people may not be aware because, some of these things are used to poison people. What kind of medications are they using? What is the dosage? What is the duration? What is their alcohol and tobacco use? Is there any metabolic diseases? Kidney disease, liver disease, thyroid disease, diabetes. And these are all going to affect toxicity. If the patient has metabolic dysfunction, is there any potential there's a hereditary optic neuropathy and a family history of vision loss? Any sensory disturbances in the peripheral nervous system? They have headache, they have vertigo, loss of hearing. These are all considerations. Symptoms, loss of central or paracentral acuity, loss of contrast, color perception, usually red, and they may actually have poor dark adaptation and may be photophobic. So when doing the exam, there's no afferent defect when it's bilateral, normal. Swollen or hyperemic nerves can occur early in the disease, but usually you're going to be seeing temporal pallor late in the disease. Central and secocentral scotoma with preservation of the peripheral field is usually going to happen in toxic neuropathy. So you have a decreased acuity, they can be photophobic, and you can actually see abnormalities in the VEP or the ERG. Lab testing, complete blood cultures, urinalysis looking for toxin, heavy metal screening, B12 and folate levels if they're presenting with bilateral scotomas. And of course, we're going to make sure the optic nerves are functioning with proper neuroimaging, brain, orbits, and chiasm. So, looking for blood levels of formic acid or cyanide for the alcohols. Patients who are on multi-drug tuberculosis regimen need to have a good examination, visual acuity, biomicroscopy, dilated fundus, and as Greg said, patients who are on ethambutol and asymptomatic should receive a monthly screening. You need visual acuity, perimetry, and optic RNFL OCT. These people need to be watched very carefully for the period of time they're going to be on ethambutol. Amiodarone, they should probably be evaluated the same way about every 6 months. And if the toxicity or exposure to lead, you can do a screening for lead. So treatment, alcohol, poisoning. There have been some anecdotal reports that IV steroids been kind of helpful in salvaging vision. Linezolid, stop the medicine if they've been out for at least 5 to 10 months. Recovery could be kind of iffy. Ethambutol, no treatment other than stopping the drug. Amiodarone, you got to consider the complications and the cardiac benefits before you stop this drug. The only way to stop the toxicity of amiodarone is stop the medication, but this may be a medicine they need to stay alive. So Sildenafil, limit the use if they're predisposing cardiovascular risk factors. But again, it's a small risk in a very small number of people. I don't think that we're ever going to really come across this. Lead, remove the source. Now, all that I think was great information, but it has nothing to do with this case. Now, let's boil it down and talk about the logic here. This is just so doggone logical. There are about 10 causes of tunnel visual fields or bilaterally constricted visual fields. You just have to work through this. There are 5 optic nerve causes. There are 2 retinal causes. There's 1 intracranial cause. There's 1 psychophysical cause, bad testing in the field, and 1 default malingering, psychological, or non-organic conversion reaction. There are a number of things that we can call it. I call it non-organic vision loss. If we default there, we as eye doctors, neuro-ophthalmologists as eye doctors, we're not qualified to diagnose malingering because malingering involves gain, and there are certain things that we're not aware of. So I don't like using the term malingering. Psychological vision loss, well, we're not psychologists, so I don't like using that. I use the term, I believe, and most neuro-ophthalmologists use the term non-organic vision loss. So there are about 10 causes. All we have to do is work through them. 5 optic nerve causes: end-stage glaucoma, end-stage papilledema, where we have flat optic atrophy, optic nerve drusen, optic nerve hypoplasia, and vigabatrin optic neuropathy. Vigabatrin is an anticonvulsant for epilepsy in children 2 years or older. Pretty easy history. What are you taking? And sometimes that can be hard to get patients to recognize or admit what they're using. But vigabatrin can give you this type of visual field. It's permanent concentric field loss, drug-induced injury to the photoreceptors and ganglion cells and their axons. So take a look. End-stage glaucoma, we can look and see that. End-stage papilledema, we have the optic atrophy. We can see that. We maybe know their history. Optic nerve drusen can do this. Optic nerve hypoplasia. Right? This is not the optic nerve. The optic nerve is right here. This is a patient who had a very teeny tiny little nerve and a bilaterally constricted visual. But these are patients who are going to be asymptomatic. If they have disc drusen or they have optic nerve hypoplasia, they've had it for virtually their entire lives that they know of. They're going to be asymptomatic. And vigabatrin, well, that's something ingested. Is the patient taking an anti-seizure medicine, anticonvulsant? So there are the 5 causes of constricted visual fields involving the optic nerve. There are 2 retinal causes of bilaterally constricted visual field, retinitis pigmentosa and RP-like conditions. For the most part, we can look at that. We can see a waxy pallor. We can see attenuated vessels. We can see the bone spicular pigmentation, which may not be omnipresent, but we have an examination we can look at. PRP scarring, peripheral retinal scarring, we can look in and we can see all of that. So this is nothing that should be surprising us. We can look and we can see. Most of these things here, we can look and we can see. One intracranial cause of bilateral constricted visual field is bilateral occipital lobe infarct with macular sparing. Can be simultaneous, could be sequential. But here's a patient who has a right hemianopic defect with macular sparing, has a left hemianopic defect, macular sparing. If they were to happen simultaneously, what do we have? There are your constricted visual fields. That's going to show up in imaging. The CT with contrast will find that. So that should have been easily found. Should easily be found with imaging. One psychophysical cause, bad testing. Fatigue or inattention, as was said earlier, there's a clover leaf. The patient's falling asleep. Those points were tested first. They drifted off. Artifact, lens artifact. Pretty easy to identify. Remove it, repeat it. It gets better. Or poor instruction. Now, here is a hemianopic defect. These were absolute zeros right along. This was an ocular hypertensive patient I had seen several years ago. The patient was undergoing their very first visual field. The student, I was still at university at the time, she gave bad instruction. She didn't tell the patient, we're going to start off and test your right eye first. She said, we're going to test your right side first. Said it probably several times. The patient was under the impression that she should ignore everything on the left, which she did perfectly well. When we repeated it, it was a clean field. And when all else fails, what do we have? Non-organic. Could be psychological. I don't like to use that term. I'm not a psychiatrist. Malignant, I don't like to use that term. I can't catch that. I don't know what they're trying to gain. I just say we default to non-organic. I love this. There's 10 causes. If we just work our way through, we're going to get to all of them. So what was the outcome? Neuroimaging was already normal. Serology was done. Low B12 levels. Greg, I think you told me the answer was 1 pill B12 supplement solved everything. The visual field came back normal. Is that correct?
That is correct. Yep.
So what is our outcome? We work through it logically. Non-organic vision loss. So what's the pertinent information here? Acute simultaneous bilateral constricted fields, not respectively vertical or horizontal, disc and fundus normal. Initial imaging, which is probably pretty good, was normal, strongly considered toxic. I consider toxicity. I thought there was something going on there, but what are the red herrings? It wasn't a secocentral sarcoma. They were constricted fields. Greg, interestingly, when I thought about putting this lecture together, I thought I would have trouble filling 1 hour. We've done 2 hours, and I'm still not done yet. So I think this is probably a good place to take information from any other questions, and maybe start wrapping things up. Belara mentions repeating the visual field could have helped. Yeah, possibly. What wasn't my call? I wasn't actually seeing the patient. I only had my suspicions, but I said when you are confronted by bilaterally constricted visual fields, remember there's only 10 potential causes. We can see these. We can see these. This is what is easy to find with imaging. Psychophysical, this is probably more common than we realize. This, as Laura says, repeat the test. And when all else fails, we get down to a non-organic field loss. Greg, is there any other questions or anything you want to add? I think we should start wrapping things up here.
Yeah, I think, the only thing I'll add was to that was I think the visual field was repeated actually 3 times. It was repeated and got that same non-organic type of field. And then after the B12, everything went away. So.
And I don't think I really talked too much about this, Greg, but I can't tell you how much I really like this case. It really fascinated me because it was just so doggone logical.
Yeah, it was fun. Fun case. So. Well, Joe, you're getting your virtual round of applause here. Great presentation. Thanks, guys. Tangent screen. There you go. Good on tangent screen. That's someone that watched Batman and Robin. I know that for sure. Maybe black and white. So, all right. All right. Getting all the nice thank yous in there, Joe. So I guess I'll share my screen here and got all the questions. And we'll wrap this up and say thanks to everyone. And Joe, thank you. And Joe, as you know, you've taught me a lot of neuro over the years. Still love learning from you, and you like how you carve it up and make it palatable and understandable to help us in clinic the very next day. So great job and thank you.
Thanks. I think that these cases show that when you need help, you can send up the bat signal, and we're going to come running. We're going to come. We're going to help you, and there's a heck of a lot that can be done via text, via phone call, via email. So don't be afraid to reach out.